coordination reaction using antigen-coated carrier particle, including red blood cells or latex particles, or enzyme immunoassay. Fluorescence and staining of tissue section has also been used to determine disposition of immune complexes in the tissues. The staining pattern seen and the particular tissue affected helps to identify the disease and determine its severity. A more general method of determining immune complex disease is by measuring complement levels. Decreased level of individuals' components of decreased functioning of the pathway may be indicative of antigen-antibody combination. The result must be interpreted with regard to other clinical findings. Now we're going to discuss about the type 4 hypersensitivity. Type 4 or delayed hypersensitivity was first described in 1890 by Robert Koch, who observes the individual infected with Mycobacterium tuberculosis develop a localized inflammatory response when injected intradermally with a filtrate from the organism. Type 4 hypersensitivity differs from the other three types of hypersensitivity in the sensitized T cells. Usually, a subpopulation of T helper cells 1 plays a major role in its manifestation. Antibody and complement are not directly involved. There is an initial sensitization phase of 1 to 2 weeks after the take place after the first contact with antigen. Then upon subsequent exposure to the antigen, symptoms typically take several hours to develop and reach peak 48 to 72 hours after exposure to antigen. The reaction cannot be transferred from one animal to another by means of serum, but only through transfer of T lymphocytes. Langerhans cell in the skin and macrophages in the tissue capture and present antigen to T helper cells of the T helper cell 1 subclass. Th1 cells are activated and release cytokines including interleukins 3, interferons gamma, or the IFNY or the tumor necrosis factor beta, and tumor necrosis factor alpha that recruits macrophage and neutrophil produce edema, promotes fibrin deposition, and generally enhance inflammatory response. Cytotoxic T cells are also recruited and they bind with antigen-coated target cells to cause tissue destruction. Allergens, skin reaction to bacteria, viruses, fungi, and environmental antigens such as poison ivy typify this type of hypersensitivity. Now we're going to discuss about the contact dermatitis. Contact dermatitis is a form of delayed hypersensitivity that accounts for a significant number of all occupationally acquired illnesses. It is estimated that 15 to 20% of the Western world population is allergic to one or more chemicals in the environment. The reactions are usually due to low molecular weight compounds that tough the skin. The most common causes include poison ivy, poison oaks, and poison sumacs, all of which give off a rosal in the plant tops and on the leaves. Allergic dermatitis due to contact with these three plants affected between 10 and 15 million Americans every year. Other common compounds that produce allergic skin manifestation includes nickel, rubber, formaldehyde, hair dyes, and fabric finishes, cosmetics, and the medication applied to the skin such as topical anesthetic, antiseptic, and antibiotic. In addition, latex allergy has been reported to affect between 3.8 and 17% of all healthcare workers in the United States. Most of these substances probably function as hapten that binds to glycoproteins on skin cells. The Langerhans cells, a skin macrophage, function as the antigen-presenting cell at the site of antigen contact. It appears that Langerhans cell may migrate to regional lymph nodes and generate sensitized T helper 1 cells there. This sensitization process takes place several days, but once it occurs, its effects last for years. After repeat exposure to the antigen, cytokine's production causes macrophages to accumulate. A skin eruption characterized by erythema, swelling, and the formation of papules appears anywhere from 6 hours to several days after the exposure. The papules may become vesicular with blistering, peeling, and weeping. There is usually itching at the site. The dermatitis is first limited to skin sites exposed to the antigen, but then it spreads out to adjoining areas. The duration of the reaction depends upon the degree of sensitization and the concentration of antigens absorbed. Dermatitis can last for 3 to 4 weeks after the antigen has been removed. Simple redness may fade of its own accord within several days. If the area is small and localized, a topical steroid may be used for treatment. Otherwise, systemic corticosteroid may be administered. The patient also needs to avoid contact with the offending allergens. Now, to spice things up, hypersensitivity pneumonitis. Recent evidence show that hypersensitivity pneumonitis is mediated predominantly by sensitized T lymphocytes that respond to inhaled allergens. IgG and IgM antibodies are formed, but these are thought to play only a minor part. This is an allergic disease of the lungs parenchyma, characterized by inflammation of the alveoli and interstitial spaces. It is caused by chronic inhalation of a wide variety of antigens, and it is most often seen in men between the age of 30 and 50 years, depending on the occupation and the particular antigen. The disease goes by several names, including farmer's lungs, pigeon's breeder disease, and humidified lung disease. The reaction is most likely due to microorganisms, especially bacterial and fungal spores, that individuals are exposed to from working with moldy hay. Pigeons dropping, compost, moldy tobacco, infested flour, and moldy cheese, to name just a few examples. Symptoms include a dry cough, shortness of breath, fever, chills, weight loss, and general malaise, which may begin within 4 to 8 hours after exposure to a high dose of the offending allergens. Alveolar macrophages and lymphocytes trigger a chronic condition characterized by interstitial fibrosis with alveolar inflammation. Systemic corticosteroid therapy is used for therapy. Now we're going to discuss the tuberculin hypersensitivity. Testing for exposure to tuberculosis is an example of a delayed hypersensitivity reaction. This is based on the principle that soluble antigen from Mycobacterium tuberculosis induce a reaction in people who have had tuberculosis. When challenged with antigen intradermally, previously sensitized individual develop an area of erythema and induration at the injection site. This is the result of infiltration of T lymphocytes and macrophages into the area. The blood vessel becomes lined with mononuclear cells, and the reaction reaches a peak by 72 hours after exposure. The tuberculin skin test uses Mycobacterium tuberculosis antigen prepared by making a purified filtrate from the cell wall of the organism. This purified protein derivatives PPD is injected under the skin, and the reaction is read at 48 to 72 hours. A positive test indicates that the individual has previously been exposed to Mycobacterium tuberculosis or a related organism, but it does not necessarily mean there is a present active case. Woo! That's the last topic, the testing for delayed hypersensitivity. The patch test is considered the gold standard in testing for contact dermatitis. This must be done when the patient is free of symptoms or when he or she at least has a clear test sites. A non-absorbent adhesive patch containing the suspected allergen is applied on the patient's back, and the skin is checked for a reaction over the next 48 hours. Redness with papules or tiny blisters is considered a positive test. Final evaluation is conducted at 96 to 120 hours. All readings should be done by a skilled evaluator. False negativeness can result from inadequate contact with the skin. Another type of skin test for delayed hypersensitivity, the Mantoux method, is performed in much the same manner as testing for the presence of IgE. Typically, 0.1 ml of the antigen is injected intradermally using a syringe and a fine needle. The test site is read at 48 to 72 hours for the presence of induration. An induration of 5 mm or more is considered a positive test. Antigen typically used for testing are Candida albicans, tetanus toxoids, tuberculins, and fungal antigens such as trichopiton and histoplasmin. Okay, getting sweeter right now. Now to summarize this up, you fucking idiot! Hypersensitivity reaction are exaggerated reaction to antigens that are typical, not harmful. Usually, there is destruction of host tissue in the process of attempting to destroy the antigen. Gel and Combs devise a system of classification for such reaction based on immune mediator and the nature of the triggering antigen. Type 1 hypersensitivity or immediate hypersensitivity is manifested within minutes of exposure to antigen. The principal mediator is IgE, which does not remain free in the serum but binds to mast cells and basophils. When cell-bound antibody binds antigen, the resulting degranulation of the effector cells release mediator that enhance the inflammatory response. Preform mediator that are released include histamine, eosinophil chemotactic factor of anaphylaxis, neutrophil chemotactic factor, and proteolytic enzymes such as tryptase. Together, these factors are responsible for contraction of smooth muscle in the bronchioles, blood vessels, and intestines. Increased capillary permeability, increased concentration of eosinophil and neutrophil in the area, and decreased coagulability of blood. Newly synthesized mediators such as prostaglandin, leukotrienes, and PAF potentiate that affects of histamine and other perform mediators. Buang! Sorry. Clinical manifestation of immediate hypersensitivity includes will and fair skin reaction, rhinitis, and systemic anaphylactic responses, which can be life-threatening. Tests to determine the potential for incurring such reaction includes both in vitro and in vivo methods. The non-competitive RIST measure total IgE by using radio-labeled anti-IgE that binds the patient's IgE on solid phase. RAST is a non-competitive or capture method to determine antibody to specific allergens. In vivo skin tests such as prick or intradermal tests are done by exposing the patient directly to a very small amount of allergens injected under the skin. A positive